Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Arun Jain. Sir is MBBS, DCH, MIAP, FCCS, Director and Pediatrician at Dr. Arun Child Hospital, Agra. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is functional constipation in children. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Okay, thank you for the warm welcome. And I'm really thankful to the platform IGCP for giving me this opportunity to present the management of childhood functional constipation. Initially, when I started my practice, the diarrhea part was very prominent. But as the time passes, the constipation has taken a upper lead in place of the diarrhea. So this topic, childhood functional constipation, is very much important and in our day-to-day practice. Now, the prevalence is very common. It's common in children, especially toddler and the young children, and 17 to 40% of cases starts in the first year of life. The worldwide prevalence is about 0.7 to 27.6, and the male-female ratio is more in the male compound. And they account for 3% of visits to general pediatric clinician, and as many as 30% of the visit to pediatric gastroenterologist. 30% of visits of all the pediatric gastroenterologist is because of the constipation. And 30% children with constipation develop fecal incontinence. 95% have functional constipation and only 5% have the organic causes in the age of more than 1 year. Now, functional constipation definition we see, you have to rule out no underlying cause or any underlying pathology. So this is very important that there is no underlying cause or any pathology condition in a child more than 1 year. If there is a cause, then we don't label it as a functional constipation. Now, what are the causes? The changes in the diet, stressful event, postponing of the defecation, too early toilet training. So what happens? It causes prolonged fecal stresses, reabsorption of fluid, harder stool, more pain, more painful defecation, voluntary withholding. So it's a vicious cycle which is taking place nowadays and leading to functional constipation in the children. Now, Rome has defined a criteria, and the modified 4 criteria are there. Include, this is a very important slide. It says it must include 2 or more of the following condition occurring at least minimum of 1 week for minimum period, which is mentioned here, and insufficient criteria to diagnose the irritable bowel syndrome. So 2 or fewer defecation in the toilet per week in a child, at least 1 episode of fecal incontinence per week, history of retentive posture, excessive stool retention, history of painful or hard bowel motion, presence of the large fecal mass in the rectum, history of large diameter stool that can obstruct the toilet. So 2 or more of these features, and after appropriate evaluation, the symptoms cannot be fully explained by other medical condition. So again, the causes, 90% is the functional constipation, 5 to 10% are the other causes. They are motivated Hirschsprung disease, congenital anomalies, anal stenosis, anterolocated anus, cerebral palsy or mental retardation. It can be because of the endocrine or metabolic disorders like hypothyroidism, diabetes, hypercalcemia, the drugs like anticonvulsant, antipsychotic, codeine-containing antidiarrheal. So investigations are seldom required. So this is very important that the diagnosis of functional constipation is clinical. The plain X abdomen, obese thick bald hair, other PR is not possible. Then ultrasound if you are suspecting voiding dysfunction or the history of UTI, thyroid profile not treated unless there is a clinical suspicion, because hypothyroidism itself is one of the major causes of constipation. Now there comes the clinical features. The symptoms of constipation are infrequent stool, aneurysms or other urinary symptoms, blood in the stool, abdominal pain, fecal soiling, and stool withholding maneuvers. Now, in this, what happens? The child doesn't want to pass the stool, so he just take the maneuvers of crossing the leg, hiding behind some furniture or the curtain. So he just want to avoid the stool passing the stool. Now, this is the normal Bristol school charting. You have to take a history. If you see type 1, very hard lump, or type 2, lumpy or sausage-like, so that first show very constipated and this is slightly constipated. And type 3 and type 4, sausage type and a smooth sausage type, they are normal. So if you take a proper history, then you can very well say it is a constipation or normal, or it's lack dietary fiber, it's inflammation, and type 7 is the what we see in the diarrhea, very common. Now, what can be the constipation? The child is constipated, is left untreated, following complication might occur: anchopesis, that is fecal soiling; aneurysm, that is bad wetting; recurrent UTI secondary to dilated colon and retained stool; prolapse and rectal ulceration. Now, if you come to the management part, you see there are the 4 steps in this: education, behavior therapy, dietary management, and pharmacological therapy. Now, pharmac treatment, that is treatment with the drugs, is the last part. The most important is the education to the patient, attendant to the patient, therapy, behavior therapy, the diet, which is a major concern nowadays, because most of the children are taking junk food. They are taking a lot of colas, junk food. They are not taking the proper feed. They're taking the food which is lacking in fiber. So here is the education. What we will do? We will counseling the parents about the disorder and need for prolonged treatment, educate about precipitating factors that help to alleviate anxiety. The behavior therapy, advice on toilet training, that is regular sitting in toilet 5 minutes after major meal. So the toilet training, the age is 2 years and above. Mind it, you should not advise toilet training less than 2 years of child. उसमें आपको ये बताना है कि जब भी बच्चा खाना खाए तो उसके 5 मिनट के अंदर अंदर उसको जाके पॉटी में बैठाना है. तो दैट्स वेरी इंपॉर्टेंट. ये आपको 2 या 3 बार करना है दिन में, and that has to be prolonged for 6 months. So the toilet training is a very important part in unhurried time on toilet cleaning and soiling, help to regularize toilet routines, discourage stool withholding, and improve understanding of defecation dynamics. Persistent use of diapers delays toilet training. And again, this has become a very, very important part, because nowadays most of the mothers are using diaper and the child doesn't pass stool because uske paas diaper hai, so he doesn't know when to pass and when not to pass. So he's confused state of mind. He's withholding the stool. And that is one of the major causes of constipation nowadays. Now, what about the diet? You should encourage your patient to take a lot of fruits. Fruits में cold drinks, juices, ice creams, don't advise. You have to increase the normal food, जैसे कि दाल, चावल, roti, sabji, फल, and salad. So increase the fiber in the form of salad and the normal food which we are cooking in our day-to-day practice in the rasoi. And increase diet-rich fiber, fruits encourage करिए, the normal salad को encourage करिए. What we have to avoid? We have to avoid maida. Lot of children are eating the noodles, maida, momos, pizza, burger, patties, and bakery products, biscuits should not be given to children. Biscuit chai is very combination is very popular in our practice. In we have seen the mothers are सबसे पहले biscuit chai देती हैं, which is should not be encouraged. और मिल्क की मात्रा बहुत ज्यादा होती है हमारी डाइट में, माँ की बच्चों में जो देती है हमेशा मिल्क बेस्ड डाइट देते हैं. सो बहुत ज्यादा मिल्क नहीं लेना है. फॉर एग्जाम्पल इफ यू सी 10 kg चाइल्ड, एक जो 2 साल का बच्चा होता है, तो माँ आके बोलती है कि मैं उसको 1 किलो दूध पिलाती हूँ पूरे दिन में. तो यू कैन इमेजिन कि वो बच्चा खाना कैसे खाएगा. मैक्सिमम 10 किलो के बच्चे में हाफ लीटर मिल्क काफी होता है. तो इसलिए अगर 2 साल का बच्चा है और 1 साल से ऊपर का बच्चा, उसको कम से कम 5 टाइम्स फूड चाहिए होता है इफ द एज इज मोर देन 1 ईयर. एंड ये सुन के मदर्स को बहुत ज्यादा ताज्जुब होता है. एंड दे कांट बिलीव कि बच्चे को, 1 साल से ऊपर के बच्चे को 5 टाइम्स खाना, मतलब दाल चावल रोटी सब्जी फल एंड सैलेड, इसको खाना कहते हैं. ये क्लियरली आपको अपने पेशेंट्स को एक्सप्लेन करना है. उसको हमेशा फाइबर रिच खाने के लिए एंकरेज करना है, जंक फूड के लिए डिस्करेज करना है. जो फास्ट ड्रिंक्स है, सॉफ्ट ड्रिंक्स, हार्ड ड्रिंक्स, इस के लिए अवॉइड करना है. नाउ वी कम टू द मेडिकल मैनेजमेंट. इसमें 2 पार्ट्स होते हैं. जब बहुत सीवियरली कॉन्स्टिपेटेड बच्चा होता है तो उसका जो कोलोन है पूरा फीकल मैटर से वो होता है, भरा हुआ होता है और काफी ज्यादा वाइड हो जाता है. तो पहला होता है डिसइंफेक्शन. डिसइंफेक्शन मीन्स यू हैव टू रिमूव द हार्ड स्टूल फ्रॉम द कोलोन, एंड आफ्टर दैट यू हैव टू मेंटेन द थेरेपी सो दैट उसको बार बार ये प्रॉब्लम ना हो. एंड दैट द मेन थिंग इज द laxatives. Now, what is disinfection? Fecal infection is presence of large fecal mass in the rectum or abdomen. Disinfection is the first step in the management of pediatric constipation. Preferred route of the drug is oral or rectal route. Now, oral route is more preferred as rectal route is invasive and adds to fear and discomfort of the child and may aggravate defecation avoidance. So the options available are rectally administered enemas or high dose polyethylene glycol with or without electrolytes for 3 to 6 days. So this is a very, very important part, the polyethylene glycol for 3 to 6 days. So PG, that is polyethylene glycol, is recommended as the first choice for disinfection. Again, this is a very important thing to note. So maintenance therapy में क्या होगा? There are 4 categories. First is the osmotic laxative, that is polyethylene glycol, lactulose or sorbitol. This is the first category. The second are the stimulant laxatives. This is bisacodyl, cinna, sodium pycosulfate. Stimulant laxatives are given for a very short time. Osmotic laxatives has to be given for a very long time, 3 to 6 months. Lubricants are for temporary use, alcohol suppository, mineral oils, occasionally used, and bulk forming laxative isabol is again in the long-term use. So, management, osmotic laxatives, they are the first step in pharmacological treatment of functional constipation. They are poorly absorbed, lead to accumulation of hyperosmolar particles, so they retain water and they soften stool, increase peristalsis through the intestinal distension. So only is a mechanical process के through ये अपना काम करते हैं, तो इनका side effects बहुत कम होते हैं, and that is why they are the drug of choice nowadays. Stimulants एक second line होते हैं when osmotic laxative are insufficient or act directly on intestinal mucosa, stimulates intestinal motility, increase the water and electrolyte secretion. Bulk following, they are merely the dietary fiber, which are not absorbed by the small intestine, absorb excessive water, soften stool, and increase fecal mass to stimulate peristalsis. And lubricant are the softened or lubricated stools. They are poorly absorbed and exert osmotic effect. So these are the 4 categories. The most important are the osmotic laxatives, and we will discuss in detail about this. So this is the table which shows what are the types of osmotic laxatives we have got for maintenance therapy. Polyethylene glycol, the dose is 0.5 to 1 gram per kg per day for children more than 1 year of age. The side effects are bloating, abdominal pain, cramps, vomiting, and loose mood stools, and it is safe for both short and long term. The disaccharides, they are the lactulose and lactitol. Lactulose is non-absorbable synthetic disaccharide, consists of two molecules of galactose and fructose. And the dose is now lactulose can be used in less than 1 year. So if a child is less than 1 year, you use lactulose or lactitol. But if a child is more than 1 year, then the drug of choice is PEG, yani ki polyethylene glycol. Now we take lactulose up to 1 year. It is for 1 month, say below, don't use it. 1 month to 1 year, 2.5 ml BD. 1 to 5 year, 2.5 ml to 10 ml BD. And 5 to 18 years, 5 to 20 ml BD. It causes abdominal distension and discomfort. Lactulose undergoes fermentation colon to yield short chain fatty acids, CO2 and H2. Now, among the disaccharides, lactulose and lactitol, lactitol is now preferred. It is a monohydrate. Allele or lactulose consists of lactose and sorbitol, and the dose is 250 to 400 milligram per kg per day, or 15 ml में it is 10 gram of lactulol monohydrate. So, 10 kg में it will be the 5 ml BD हो जाएगा. It is more palatable and better acceptable. Now, stimulant laxatives used only as rescue therapy. No randomized controlled trials available in children regarding their efficacy. They are usually required as rescue therapy and acute or sudden episode of constipation while being on regular campaign or maintenance therapy. They are given for a short duration of 2 to 3 days to tide over the acute episode of constipation, and then they are stopped. And these are the bisacodyl. They act by stimulating colonic motility, promoting secretions and inhibition of absorption of water and electrolytes in the colon. Their oral effect comes in 6 to 8 hours. They are single at bedtime. 3 to 10 years में 5 milligram per day, more than 10 it is 5 to 10 milligram per day, should not be used in children below the 3 years of age. So short-term usage is free from side effects. Abdominal cramps होते हैं, diarrhea, hypokalemia, proctitis is rare, and contraindication in children with proctitis and fissure. Sodium picosulfate is normally is used in our day-to-day practice for 3 to 5 days as a short-term therapy, and active metabolites that is produced by the intestinal bacteria and increase the patches of the gut. Single dose होता है 1 month से 4 years per 2.5 to 10 milligram per day, and more than 4 years to 18 years 2.5 to 20 milligram per day. It is available as a liquid form, and the Piclin is a very common trade name which is available in the market. It may cause abdominal pain, nausea, and diarrhea, contraindicated in setting of proctitis and gastric distension, underlying intestinal obstruction, or peptic ileus. Now, this is the main drug which we are going to discuss. This is polyethylene glycol, and the short form is PEG. It is a game changer laxative. So it is commonly known as macrogol, non-toxic, chemical inert, water-soluble polymers belong to a class of osmotic laxative. Now they come in different size of molecular weight, 3200 and 4000. They are minimal absorbed in the GIT, doesn't influence the movement of other solutes, and it carries no charge. Now it is both used for the disinfection also as well as the maintenance therapy. So disinfection के लिए we have only one drug, that is PEG. Maintenance में we can use either lactulose, lactitol or PEG, but PEG is the drug of choice nowadays in the child more than 1 year. So this dose is very important. It's a disinfection. That mind it, the dose is high, 1 to 1.5 gram per kg per day, और dissolve in water करके उसको देते हैं slowly, ओरली, और मेंटेनेंस थेरेपीज की जस्ट हाफ हो जाता है 0.3 to 7 ग्राम पर केजी पर डे. Disinfection usually we give for 7 to 10 days, but maintenance therapy we give for at least 2 to 3 months. So this is very important. Disinfection में आप उसको 1 कप पानी में डिजोल्व करके बच्चे को आधा पौन घंटे में उसको दे सकते हैं. Again, maintenance में भी it's very important. You give it for 3 months and gradually withdraw. Sudden withdrawal से दोबारा से होने के चांसेस ज्यादा रहते हैं. Follow up initially weekly, then fortnightly, then monthly till the stool is normal. Stool diary is helpful because you have to ask the parents कि आप इसकी frequency की चार्ट बनाइए. Because what happens, जैसे ही आप इनको पीजी पे बच्चे को स्टार्ट करते हैं, तो जो उसके कोलोन के मिड में तो हार्ड स्टूल होगा, तो वो उसको डिसइंफेक्शन में टाइम लगेगा. लेकिन जो फ्रेश स्टूल है वो साइड से बच्चे का आ जाएगा, तो फीकल सॉइलिंग के चांसेस बढ़ जाते हैं और पेरेंट्स को लगता है कि ये डायरिया है तो वो स्टॉप कर देते हैं. तो जस्ट ask them to maintain a diary and you have to tell them that listen, initially 2 to 3 days, slightly loose stool might come, so don't get panicky about that. Start reducing dose gradually only after child is toilet trained and remains symptom free for the minimum of 8 weeks. So this time, again, very important. Most of the time we have seen the compliance of the patient is not good. Patient जैसे ही ठीक होता है, abruptly parents इसको stop कर देते हैं medicines को, और दोबारा से they came with the same problem. So that cycle go on again and again. और normally वो एक पेशेंट क्लिनिशियन के पास जाएंगे, फिर दूसरे पे, फिर तीसरे पे, तो ये सिलसिला चलता रहता है. So this is the catch point. At least tell the parents before you start the therapy, listen, initially I will give high dose, will take disinfection, will take 7 days, 10 days, and then maintenance therapy will be at least for 2 to 3 months. उसके बाद भी gradual withdrawal होगा, no abrupt stoppage of treatment. So the common cause of recurrence is premature withdrawal of laxative. Outcome is better if we intervene early. So the prognosis 50% recover and can be taper off. 30 to 40% have to continuously take medicine for many years, and 10% injectable require referral. So long-term therapy is there at least 2 to 3 months and gradual withdrawal. Toilet training has to be done for at least 6 months. अगर आप ये accomplish कर पाते हैं, only then you will be able to treat your child successfully of a case of functional constipation. Now, two salts, as we have told, they are available in the market, PG 4000 or PG 3350. Now, PG 4000 have several advantages over the PG 3350. PG 4000 is liquid formulation, better taste, better pediatric acceptance, sodium free, sugar free, water soluble colorless liquid, ready for use, doesn't require dilution. नॉर्मली जो चीजें अवेलेबल है मार्केट में, पीजी थी उसको डाइल्यूट करना पड़ता है और काफी ज्यादा 50 to 100 ml में उसको देना पड़ता है. तो कभी कभी क्या होता है कि बच्चे उसको नहीं लेते हैं एंड दे हैव बिकम वेरी फसी कि उनको नहीं लेंगे उसको. तो पीजी 4000 में एडवांटेज है कि उसमें डाइल्यूशन की जरूरत नहीं पड़ती, तो स्मॉलर वॉल्यूम में ही काम चल जाता है एंड वी कैन मिक्स इट लाइक वाटर, मिल्क, फ्रूट जूस. And PG33 को preferred use water. Side effects are few in PG 4000 and approved from 6 months of age with excessive clinical data. So here it is also advantage. Approval is 6 months beyond a PG 3350. Traditionally, we give in children more than 1 year of age, and it has been approved by IAP, SPAGAN, and available globally in more than 23 countries. Thank you.
Thank you so much, sir, for your wonderful presentation. We do have some question if you'd like to take that up, sir.
Yeah.
So, sir, the first question is, what are the key considerations in the management of constipation in a child who is transitioning from exclusive breastfeeding to solid foods?
Yeah, it's a very important question. Like from breastfeeding to a solid food, can have they mentioned the age of the child?
No, sir.
Okay, because he's from breastfeeding to solid food, the age must be less than 1 year of age. In that case, you can take the lactitol is the drug of choice in that cases, and that can be given in those cases. But again, I would like to emphasize that constipation अगर हो रहा है from breastfeeding to a child who's on the stage of weaning, इसका main cause in our country is excessive of milk. Exclusive breast milk is there for 6 months. Again, 6 months ke beyond, you have to give complementary feeding. That is the weaning process, like dal or sabji, semi-solid form में उसको देना आवश्यक है. लेकिन what we have seen in our day-to-day practice, most of them are giving milk even beyond 6 months of age. ब्रेस्ट मिल्क के अलावा उसको गाय का या भैंस का दूध ऊपर से देते हैं. और स्टार्ट भी करेंगे तो बिस्कुट चाय से स्टार्ट करेंगे. Very few patients are giving proper food at the age of 6 months of age, leading to constipation, leading to anemia, and so many diseases, malnutrition also. So first you check so whether your patient is giving the food twice at least. एक बार दाल, एक बार सब्जी in semi-solid form without मिर्ची, लेकिन नमक होना चाहिए. So dietary counseling is again a key. A very important role of diet is there. So first advice on the diet, and if the child is not improving, only though उसके बाद ही you advise him the medicines. That's a very important question, and most of the patients are doing this blunder of not giving solid food. They are just on the milk. If
Thank you,
that is
sir.
diluted milk, बॉटल से पिलाते हैं वो लोग, तो बॉटल फिट नहीं बंद करना है. और ऊपर का मिल्क देते भी हैं तो उसमें पानी नहीं मिलाना है, चाहे भैंस का हो चाहे गाय का हो. प्लीज एडवाइस योर पेशेंट अकॉर्डिंग. यस,
Thank you,
नेक्स्ट.
sir. The next question is, what factors should we consider when managing constipation in children with developmental disabilities or other chronic condition?
Yeah, this is a very big challenge in our special children. The problem is that कि उनकी जो chewing capacity is very less, so they are not able to take a solid food. So you have to make a puree. So don't give too much of milk. Just avoid milk. Milk and biscuits इनके लिए और ज्यादा problem create करता है because fiber is not going. So what you can do, you can make a puree. Like दाल बनाया, उसको बहुत पतला ना हो, बहुत गाढ़ा ना हो, इतना हो जैसे कि आप सपोज एक चम्मच में आप दाल लेते हैं. अगर वो पूरी आपकी दाल गिर जाती है, वो भी नहीं देनी है. अगर आप चम्मच में दाल लेते हैं, वो दाल आपकी चम्मच में स्टिक कर जाती है, तो वो भी नहीं देना है. इसके बीच का सेमी सॉलिड वो इन बच्चों को देना है. सो यू हैव टू लर्न दैट थिंग ऑफ ग्रेजुअली. मदर एंड चाइल्ड का कोऑर्डिनेशन से आप उसको कितना सेमी सॉलिड फॉर्म में दे सकते हैं, ये एक बनाना पड़ेगा. और ओकेजनली फॉर शॉर्ट टर्म यू कैन यूज these laxatives, but if condition is very severe, like there's a hard palate stool which we have shown in the Bristol charting, then you have to give the laxatives along with the diet and plenty of fluids for at least 3 to 6 months along with the toilet training. So if you combine diet, toilet training and medicines, I think you will get a great achievement in this case.
Thank you, sir. There is one last question. What step should be taken if a child with functional constipation does not respond to initial treatment measures?
The most common factor for our treatment failure is, first of all, the child is not following a diet plan, which is one of the most common factor in our day-to-day practice. The second is the what I have mentioned. Most of the pediatrician or general practitioner give it the maintenance dose, जो उनको MR बता के जाता है. Disinfection is very important because the whole of the colon is filled with the hard fecal matter. So the cause of failure is the hard stool which is there in the colon. So you have to give a very high dose of PEG, 1 to 1.5 gram. You can increase up to 2 gram. So first you have to uh, disinfection of the gut is very important. The gut is cleared of the stool, then you have to put you on the maintenance therapy. Even if the child is not responding, then you have to look for the organic causes, and then you have to investigate thoroughly what is the problem. You may be having some organic causes, and then accordingly you have to treat that child.
Thank you so much, sir, for answering all our questions. That's all from our audience. And before concluding, sir, any last remark from you?
Yes, what I want to emphasize that nowadays all our parents are very busy in junk foods. डेली भी सी की पेशेंट जो आते हैं हमेशा कंप्लेन करते हैं कि मेरा बच्चा पनप नहीं रहा है, और जब हम हिस्ट्री लेते हैं then it's a junk food, colas, Pepsis that has leading to the constipation and malnutrition in a rich affluent society. So always encourage your patients to and parents to give them the healthy diet that is the normal Indian जो रसोई में खाना पकता है दाल चावल रोटी सब्जी फल and salad, and ask them to make a proper history, take a proper history. और एक और बहुत इंपॉर्टेंट है कि इंडियन टॉयलेट इज बेटर देन द वेस्टर्न टॉयलेट. अगर आप वेस्टर्न टॉयलेट का यूज करते हैं तो मेक इट अ पॉइंट कि बच्चे के जो पैर लटकने नहीं चाहिए, they shall be stool to support it, and the angle between the legs should be 90 degree, and between the upper body and the leg should be 30 degree. I'm repeating, put a stool at a level so that the angle between the legs at your ankle joint is 90 degree, and the angle between the body and the leg is 30 degree in a western toilet. And use same toilet again and again. Don't change the toilet frequently, and preferred is Indian toilet. So toilet training is very important, and of course diet, plenty of fruits, rich habits, exercise, they are the key component जो उनको encourage करना है. Sedentary habits बच्चों में बहुत ज्यादा बढ़ती जा रही है, जिसकी वजह से कॉन्स्टिपेशन के केसेस डे बाय डे इंक्रीज हो रहे हैं. अगर हम सभी चीजों का ध्यान रखेंगे तो डेफिनेटली वी कैन प्रिवेंट फंक्शनल कॉन्स्टिपेशन इन अवर चिल्ड्रन. दैट्स ऑल.
Thank you so much, sir, for joining us today. And with your permission,
थैंक यू.
sir, I would